Good evening. I'm Roy Cameron, Executive Director of Homewood Research Institute. Welcome to all of you. I'm so glad you were able to join us this evening. Homewood Research Institute is unique in a couple of ways. First, our focus is on research that has immediate application to improving practice. Second, we work with independent researchers, leading people across Canada and beyond. Homewood Research Institute was founded by and continues to be supported by Homewood Health. We continue to work together to do practical research, although HRI remains arm's length from Homewood Health. I'd like to begin tonight by acknowledging that the offices of Homewood Research Institute are located on the traditional lands of the Anishinaabe, Attawattaran, Haudenosaunee, and Métis peoples, and the treaty lands of the Mississaugas of the Credit. Most of us are settlers whose access to this land is rooted in a history of colonization and occupation. We grew up learning about Indigenous peoples referred to in the past tense. However, we recognize that their relationship with the land we are on continues to this day. We acknowledge the living trauma that our history as white settlers has created. As people working in the mental health field, we understand the deep impact that these traumas can have on current and future generations. At HRI, we support the Truth and Reconciliation Commission of Canada's calls to action. We support decolonization and positive change. We are learning how to be more inclusive in our research and everyday practices. If you have suggestions for how we can improve our practices at HRI, please contact us. This is not just a pro forma reading of a land acknowledgement. As people who do trauma research, we understand the impacts that First Nations, Indigenous people have had. And we want to do our small bit in the larger effort to promote reconciliation and healing. It really is a delight tonight to launch this series. The aim of the HRI Talks is to present interesting emerging research findings, and we'd like to do that in a way that, as possible, gives people some insights into things that they can do to better manage their own mental health or promote the mental health of their family, friends, and co-workers. This particular session is really timely. We felt we wanted to start with trauma because we live in a COVID world. COVID has had damaging impacts on our economy, on families, on individuals, on work sites, on all kinds of organizations. In order to move through this, our primary responsibility as citizens is to follow public health advice so that this pandemic passes as quickly as possible. Meanwhile, Homewood Research Institute is invested in doing research that will help understand how organizational leaders and individuals can build resilience as we deal with this continuing pandemic. We want to talk about that research tonight. This session, as you'll probably know, is being recorded. We're going to post it on YouTube so that you can share it with people afterwards. To overview the session, it'll be a moderated conversation. There'll be opportunities to ask questions. Please, to ask your questions, use the Q&A box at the bottom of your screen. The conversation that we're going to have may trigger reactions in some people. If you have a need for access to resources, please go to wellnesstogether.ca. This is a Health Canada resource available free of charge to people right across the country. I want to thank our sponsors, CIBC, KPMG, and Fusion Homes. Without these sponsors, this evening would not have been possible. I'd like now to introduce our speakers, Dr. Margaret McKinnon and Dr. Alex Hebert. Margaret McKinnon is Homewood Chair in Mental Health and Trauma. She's a professor in the Department of Psychiatry and Behavioral Neurosciences at McMaster University, where she's also Associate Chair of Research. She's the Mental Health and Addiction Research Lead at St. Joseph's Healthcare Hamilton. She's a highly regarded Canadian leader in trauma research. Her work focuses on understanding the full spectrum of damage caused by trauma, guilt, shame, cognitive dysfunction, a whole range of problems that arise when trauma occurs. Then she develops novel treatments to address trauma in all its dimensions. She's working with military, veterans, first responders, healthcare workers, civilians. So she has experience working with populations dealing with trauma right across the board. We're fortunate at HRI to have Margaret leading our trauma research program. Thank you for joining us tonight, Margaret.
Right.
I also want to introduce Dr. Alex Bear. This too is a pleasure. Alex is chief psychiatrist at the Veterans Affairs Canada. She has 35 years of experience as a nurse and as a psychiatrist. She joined the Canadian Armed Forces in 2006. When she retired, it was with the rank of Lieutenant Colonel. She's an associate professor of psychiatry at the University of Ottawa. She regularly publishes and presents internationally. So just to pause a moment, both Margaret and Alex are bona fide clinicians who work with patients as well as doing research. That brings a richness to the conversation we'll have tonight. Alex helped develop the federal framework on PTSD, and particularly pertinent to tonight's topic, she is chair of the task force on COVID-19 Readiness Resource Project for the Canadian Institute of Public Safety Research and Treatment. That task force developed a resource for first responders. We'll share the link to that resource tonight. So welcome to both of you. Thank you so much for giving of your time to join us. Margaret, you've been exploring the mental health impacts of COVID-19 on individuals, families, particularly healthcare workers, first responders, and public safety personnel. What have you learned from the people you've been working with?
Thank you, Roy, so much for that question. And I just wanted to begin by thanking those individuals, so healthcare workers, first responders, and public safety personnel for their service during this pandemic. And as Alex, I'm sure, would agree, we work very closely with the military. And I think one of the highest honors we can say is thank you for your service. We really want to say that tonight. We also recognize, the tremendous impact that this pandemic has had on healthcare workers, first responders, and public safety personnel. When I go in and I do clinical work right now with healthcare workers, I often say it seems like healthcare workers are living in a different world than civilians, people who are not healthcare workers, and that tends to really resonate. The experiences that they're having right now are tremendously difficult. There's hope, of course, in the team and the team spirit, but this has come at a cost to individuals and also to their families. We know that many healthcare workers are staying in their positions because they want to support their team, their brothers and sisters at the hospital, but they also are doing this at tremendous sacrifice. So time with their families, being in situations that may cause moral injury, which we'll talk about later on this evening. And I want to also acknowledge here public safety personnel, because when we talk about the term public safety personnel in that includes officers, border patrol officers, police, fire, ambulance, dispatchers. Many different individuals contribute to keeping us safe here in Canada and also caring for us during this pandemic. So we've been conducting research in collaboration with Homewood Health, along with the Center of Excellence on PTSD in Ottawa. And we're going to be talking a bit about those research findings today, but I want to begin here first by thanking these individuals for their service and also recognizing the impact this has had on them and on their families. I think it's really important to acknowledge both here tonight. Oh, Alex, if you have any other thoughts surrounding that question.
Thanks, Margaret. I think the only thing I would add is, yes, thank you very much for thanking all of these people. And I think, one of the things to say to begin with is that public safety personnel, healthcare workers, and military people, all these people who we kind of put in this group of first responders, that these are people who, in their everyday work life, they're dedicated to serving others, they're prepared, they are highly competent professionals, and they are masters of dealing with wicked problems
Mm.
and making tough decisions. They do this every day in their jobs. So it it really speaks to the effects of COVID, that this has caused distress so widely in this population who themselves are really such competent people used to dealing with crisis and emergency.
Yeah, Alex, I have to really agree with that. I talked to some of my colleagues now in healthcare who I would never expect to be having the sort of reaction that they've had. They've been in this field for many, many years. And to see these individuals, suffering the way that they are, I want to acknowledge the suffering of healthcare workers and public safety personnel. And also recognize, as you say, it is among the most hardened of us who are now at a point where they're saying, this is enough. I've had enough. And I think as we think in Canada about the pandemic and its impact, we really need to think about the retention of our healthcare workforce and of first responders and public safety personnel. And as Roy was saying at the beginning, as Canadians, I think one of the best things that we can do is to follow those public safety guidelines and to get vaccinated, because there is a tremendous challenge right now in Canada for healthcare workers who are caring for individuals who are not vaccinated. And that comes at a really high cost. I'm looking at the impact, for example, in the healthcare system. In Hamilton today, Hamilton Health Science had to cancel cardiac surgeries because they needed to redeploy their cardiac nurses to the ICU. And I think as Canadians, we have a responsibility to do the best that we can to make sure hospitals aren't overburdened at this time, and really to care for one another.
Just to build on some of this, you were talking about the impact on the workforce, and when we hear about these impacts, we hear terms like trauma, burnout, moral injury. How do you distinguish these various experiences, and how do they fit together? Alex, could you start us off?
Sure, sure. So let me sort of define at least those first two terms, trauma and burnout. So trauma, basically, it's a reaction to an acute, usually an acute traumatic event. So an event that has often an overwhelming and negative effect on us. It can also relate to an ongoing repetitive event that, again, when we think about childhood neglect or abuse, it's often something that has been chronically happening to the child. Um, so that's kind of that's the focus of looking at a traumatic event, and of course then there are effects of that event on the person. Now, one of the things we also, I want to just explain for a minute, is that we have a diagnosis called post-traumatic stress disorder. Now, this is a defined diagnostic category that, and it has very sort of specific definitions for those traumatic events and the typical reactions that people have following the traumas. Um, so that's kind of encapsulated what talking about trauma or a traumatic event entails. When we talk about trauma, unlike when we say post traumatic stress disorder, trauma we're using more widely and more generally to talk about, again, these things that affect us in a very negative way and that kind of overwhelm our usual ability to cope. So burnout, on the other hand, is an interesting term, and it's something that actually I think it was popular, started kind of in the 80s and 90s, and then you didn't hear much about it anymore. And but recently, the last couple of years, people really are talking a lot about burnout. And it is considered an occupationally related phenomenon, not a medical condition. It's not a diagnosis. However, um, it has become significant enough that it's been defined that in the World Health Organization has a classification called the International Classification of Diseases. And they've made a definition for burnout because they think it's becoming very common and it was significant enough to talk about. So the way that they define burnout is it's a condition resulting from chronic workplace stress that is not successfully managed. And basically, there are, I think, three things that they look at when they try to decide if somebody is suffering from burnout. Um, it's sorry, give me a minute here to think about what those are. The person feels usually tired and exhausted. Another one of the experiences is that the person becomes very cynical and angry related to their work in their workplace. And the third point is that it's it's very hard for them to recover, and they often become disenchanted and they can't work effectively anymore in their workplace. So that's kind of how burnout has been defined.
Thanks, Margaret. Could you say something about moral injury and give us some perspective on that?
I certainly can. And, just following on Alex's point as well, I've been going into the ICUs and the emergency rooms. And what people talk about often is that compassion fatigue, where they're sort of at the end of their rope in terms of how much compassion they can feel right now because they've seen so much and suffered so much. And I think that's part of that picture. In some ways, compassion fatigue relates to moral injury. And moral injury was a concept that was coined originally in the military. And Bill Nash, who Alex and Ruth Lanius, who also works on this research with us, and I have the privilege of knowing Bill. And this was a notion that oftentimes in the combat theater, people are asked to, or not asked to, they have to do things that may violate their moral or ethical values, or they may have a sense that an institution or an individual who has a duty of care hasn't been able to do that. And I think Romeo Dallaire really eloquently described that when he talked about his experiences during the Rwandan genocide and when he was ordered to stand down by the UN. And for him, that felt like a violation of his moral and ethical values, but also betrayal, in that he was sent there for peacekeeping operations and he fought to protect the safety of individuals. When we turn that now to the pandemic and we think about some of the morally injurious situations that are being faced by public safety personnel, for example, paramedics going into homes right now, along with healthcare workers, this has been really challenging. I think, for example, of the provision of care, which is often seen by healthcare staff for many individuals as futile right now. We do, of course, have interventions for COVID, but in some cases, people are being kept alive in circumstances where that care may not necessarily have an impact. And for many people, that can feel like a moral injury and that it's invasive care, it can be potentially painful care. And that's been a real difficulty for our nursing staff. Certainly, we hear that all the time in the research that we're doing. And in the work that we've done at HRI, we certainly learned that the likelihood of developing a moral injury is it can be exacerbated by individuals, for example, who have a past history of traumatic experience. So, for example, those who've experienced childhood abuse or childhood neglect. And in many cases, this pandemic can really be retriggering in the sense that people may longer feel that they have a sense of control over their bodies, over their space, that other individuals like government or their employers are providing them with very strict regulations that they need to follow. And for many individuals, that can be re-traumatizing, not just around moral injury, but also around other facets of psychological response. So just remembering that, we all came into this pandemic not new, but we came in with all our past experiences too. And that really informs how we are today. I'll just make one final comment on this, and that for many healthcare workers, the same as we hear from first responders in the military, they may feel it's really difficult to share their stories with others because they really fear that they'll harm them. I think Alex said something very powerful about that the other day, about how to talk to your spouse or your partner about that. And maybe, Alex, I might turn that over to you for your thoughts there.
Sure, thanks, Margaret. Um, yeah, I think, you know, because sometimes what happens is a spouse, and we saw this, I saw this a great deal when I was treating people in the military, because
Mhm.
they often had, trauma conditions like PTSD, and they wouldn't talk to their family members, their spouse, even though their spouse was trying to offer them support,
Mhm.
because they wanted to protect them from these terrible thoughts and these terrible stories and memories that they had. And I think sometimes what can be helpful for the spouse who's trying to give support is just, if your partner can't talk about it or doesn't at this time feel they can share, is to just let them know that you're there.
Yeah.
Just be there with them and say, that's okay. I'm here and I'm ready if there's a time where you want to talk, or if there's anything I can do to help you get help from somebody, from a professional, or somebody who you feel you can talk to, but that I'm here now and I want you to know that I care about you, that so that you don't need to get the person to tell the story necessarily. What you need to do is show them that kind of unconditional support. I wanted to add another kind of another, I guess, part of moral injury that has been developed more recently, and that has been that sort of inner conflict
Mhm.
that people suffer following a violation of themselves by
Yeah.
a trusted individual or by an
Yeah.
institution. So again, people can start to have these concerns and conflicts around moral injury, or what, again, in the resource project, we often, because we were seeing people earlier in the process, right at the beginning of COVID, we would talk about it more as moral dilemmas or moral distress. It wasn't really at the point of what I would call an injury, but where they felt the institution had let them down or in some way betrayed them, that this was very difficult often for them, much more difficult than a kind of a straight on traumatic event.
Yeah, Alex, could I get you to talk, just building on that, to talk about what organizations and leaders can do to help their employees in the workforce to prevent that kind of moral injury?
Sure. Let me start on that, Roy, and then I'll ask Margaret to add, because I know, in especially her research in healthcare with healthcare workers, she's really learned a lot. So, when we developed the COVID-19 Readiness Resource Project, it's an online resource that we developed, as I said, early in the pandemic, for public safety personnel. And it was really to help them maintain their resilience. And so, we read the literature, we looked at past epidemics and pandemics, mainly SARS, where there was some really good literature that came out of Canada, actually. And but then we also interviewed many frontline workers, first responders, and we interviewed their leadership about what were they struggling with. So we that was kind of the amount of information we had to work with. And it was interesting because when we would ask frontline workers, what do you need from your leaders? They almost all said exactly the same things. And it was two things. The first was for them to be present, and secondly, for them to have my back. Because I'm being asked to do things in extraordinary situations. Margaret gives the example of nurses who work in a surgical unit and they're being deployed to intensive care. Having been a nurse, like, that is totally different set of skills. This can be very, very difficult for people, especially the highly technical skills. And so uh, one of the things that when people are being asked to kind of go out on a limb in their professional capacity like that, they really need to know that if something doesn't work, something goes wrong, that their leadership has their back. That was the thing we heard from everybody. What were you hearing, Margaret, from healthcare workers?
Yeah, thanks so much, Alex. We have been really fortunate. We've been interviewing healthcare workers across the country with support of incredibly generous donation from Homewood Health, actually the largest donation of its kind to look at the mental health of the healthcare workers and public safety personnel across the country, and also supported by the Center of Excellence in PTSD. And we've asked healthcare workers, particularly Kim Ritchie, who's a postdoctoral fellow at HRI, along with Andrea D'Alexandro, a graduate student, who I really want to acknowledge. And the number one thing that healthcare workers have said is they want that people to know their experience, to have cultural competency. And so as we come, to the table with healthcare workers and public safety personnel, we really do need to know what have they experienced during this pandemic, how difficult and morally distressing it has been, how they may feel as if they're living in a different world than others, how they've enforced no visitor policies, which is so difficult to do that. And the disruption as well in their family lives. There are people right now who have had to put parenting on hold, their relationships essentially on hold to care for others here across Canada. And I think when we know that and we can come back and say, we know your suffering, we know your sacrifice, and we thank you for your service, and we can use real words to describe that, not just superficial. I think that's when we can really provide support as well. In addition, as you say, for leaders being present and for knowing that they have your back. There is nothing more difficult than working with a leadership that doesn't have your back.
I think this is a very important point. So leaders need to have people's back. They need to understand really what those people are going through and
Yeah,
communicate that they understand and show compassion.
yeah, compassion's
Uh,
hard.
Thank you. I think that's a really important point. We can't just leave individuals on their own. This isn't just about relaxing your way through this. We
Mhm,
really have to create environments that support resilience.
absolutely.
Margaret, to build on that issue, how can healthcare workers, first responders, and public safety workers help each other or help themselves when they experience trauma?
Yeah, so I'm gonna say something sometimes we think that psychology and psychiatry are magic and that we have these magic solutions. We don't always. And sometimes it's important to think about what's helped you in the past. So when you've been in a really difficult or troubling situation, what's been helpful? Has it been reaching out to a friend, having a hot bath, having a cup of tea? That's not a panacea, obviously, but we want people to have the opportunity to reach back to what's helped them before. We also know that one of the greatest predictors of who goes on to develop post-traumatic stress disorder in the face of a traumatic or stressful event is social support. And so relying upon one another. I was meeting with someone today who said, I don't know how you do this. And I said, well, I have incredible people like Alex, Ruth Lanius, Andrew Nicholson, these incredible colleagues who I can go to and talk about what's happening, what I've seen day to day in the ICU. And I really encourage others to reach out to one another and support one another. I think another thing is that, self compassion is something we talk about a lot. And for many healthcare workers right now, they may have a sense that when they're not at work, they're abandoning the team. They feel this guilt when they're not there. And unfortunately, we really do believe that you really have to be able to put that oxygen mask on yourself before you can help others. So really encouraging people to get back to things like going to the gym, exercising, we tried something at St. Joseph's Healthcare Hamilton where we gave our leaders across the organization, I'll pull this out, just a very soft, pliable ball. And what that did is it helped them to ground themselves. So when you touch something that's very soft and pliable, that really can help you to regulate lower level brain regions. And so it's not just top down and thoughts that we need to change. It's also how do we regulate our emotions? How do we provide grounding, which we talk about all the time in PTSD? So that could be, sucking on a candy and experiencing the taste of that. It could be listening to something that you find soothing. But it doesn't always have to be a magical big solution. There are things that we can do right now to help ourselves. But also say though, of course, if this is interfering with your work, with your family life, and so on, you really should reach out for help and support, for example, through the wellness portal. We have hubs across Ontario for healthcare workers. CIPSRT has wonderful resources on their website. Just really wanting people to reach out when they need that help. There's so much stigma around mental health, particularly in healthcare. And being someone who has suffered from depression and PTSD, I think it's really important to challenge that stigma and for leaders in particular to come forward and talk about some of the challenges they've faced because it helps others to open up as well.
I think, one of the other thing to, and thank you for bringing that around to leaders, because again, one of the things we discovered when we talked to leaders was often, and especially when there's a sudden crisis like this pandemic that befalls us, leaders are also, they're used to kind of working in a certain way and, working with people in a certain way, and may have been doing their job just fine until they're in a crisis. And often they're quite frightened too, like, because they don't want to disappoint their people. They don't want to do a bad job. And I think that was one of the reactions we saw with frontline first responders, was that sometimes their leaders were very absent, and that
Um,
it seemed that this was part of it. I think the leaders were just, they weren't quite sure what to do.
um,
And so what we would encourage them to do is, again, just go there, be present. You don't have to have all the answers. and
oh,
and in fact, if one of your people asks you something and you don't have the answer, just, be honest about that and say, but I'm going to do my best to find that for you. I'm going to do what I need to do.
absolutely.
And but that relationship is, quite frankly, sometimes it's like magic.
Yeah,
Having,
yeah,
I go back to the what I had said earlier about the spouse, and supporting your spouse. Sometimes it's just to say, you know what, again, I have your back. I'm here for you. Let me know how things are going. And the
absolutely.
person may actually never even call on their leader, but that is
Um,
powerful to hear that.
It really is, Alex. And I think about how we turn that same voice to ourselves. So how do when we gave the example of the moral injury around people dying alone, and we might say, how it's very difficult as a healthcare worker to see that, and yet how grateful would the son or daughter of that patient be that you were there to hold the hand of that individual? How grateful was that individual at the end of life that somebody was there holding their hand? I think part of that is self-compassion, and we use these terms all the time for others, and it's so difficult to turn on ourselves, and particularly for people with trauma. Pride hurts, a compliment can hurt. So can you tolerate that self-compassion, even for a very small period, 5 seconds, 10 seconds, building up that compassion muscle, I think is really important.
I
What
like
I'm
that.
hearing is that it sounds like it's important to stand with people, walk with people, support people, to be open with people, and to be human and kind in the
Women,
process.
absolutely, absolutely.
Margaret, what can you tell us a bit about the research that's underway and the kind of hope it offers?
Absolutely. So we really, as I mentioned, we've been engaged in interviews with healthcare workers across the country and public safety personnel who we've also been interviewing, trying to get a sense of what their experiences have been and really to develop that cultural competency and understanding. And, we've heard about all kinds of things during the pandemic. We've identified some of those top 10 stressors that people have faced, and many of them have been talked about this evening. What we're doing now, and that's been work with the Center of Excellence on PTSD, and again with Homewood Health, working with HRI. And now what we're doing is actually working with Homewood directly and the clinicians at Homewood to develop novel treatment and intervention approaches that are tailored for healthcare workers and tailored for public safety personnel. And what we want to be able to do here is trial those approaches across different clinical settings, inpatient, outpatient. Also, many people rely upon their employer, their EFAP or their employer family assistance plan for supports. And so how can we integrate this learning and this knowledge into these approaches so that we can offer people the best possible care that's tailored to them? Because personalized medicine in many ways is, it's the way forward. And we also plan to evaluate these new approaches. So not just to say we're having these approaches, we're going to try them, but we're going to evaluate them to really know, do they work or not? Part of that is also training healthcare workers to know, and mental health providers in particular, to know that these have been the experiences. What does it look like on the ICU day to day? What does it feel like? We can't, as first responders always say, I can't be with a healthcare provider or clinician who cries when I tell my story, right? Where I have to comfort them. And we really need to do the same right now across first responders, public safety personnel, and healthcare workers. So as mental health providers, we are prepared for the stories that we're going to hear and also know the experiences. And I think that all of that is really important. And we'll also be updating the moral injury guide developed by the Center of Excellence, the Phoenix Center in Australia, with some of the learnings that we have from these interviews. We're doing surveys across the internet. We're really, really trying to understand the experiences and the challenges that first responders and healthcare workers and public safety personnel are facing. We've even been contacted by groups as diverse as funeral directors who are saying, think about the impact on me as well. This has been spread across Canadian society. I think I mean, I don't say this lightly. I think we're in a war right now. And I don't say that lightly at all. And all of us.
Okay, and it's great that you're doing that kind of work, Margaret, to look for solutions that are tailored to the needs of the people who are incurring those injuries. Alex, what thoughts do you have about developments that bring hope to you?
Yeah. So to talk again about the idea of cultural competence in therapists and workers who are working with these folks and hearing these stories. Because Margaret had mentioned earlier compassion fatigue, and of course that's always one of the risks when one is hearing many traumatic stories, and especially if you're early in your career and you haven't had much experience in this kind of work. And so again, as we say to the healthcare workers or first responders, you know, make sure you have a good team around you, make sure you have that social support. I think it's the same thing for those providing the care to those folks. That is, if you need some mentoring, set it up, make sure have form a community of practice if you're a group of social workers or psychologists. And we have the virtual world now, and get together once a week and talk about those, just those difficult times that happen when you're doing therapy, so that you can support each other and maybe give each other tips, because that's really, really important. And again, we know, as Margaret said, often we can give other people that advice, but we don't take it ourselves. So I think that's, to think about how can we give social support to ourselves as well when we're doing this very difficult work.
Absolutely. Yeah, I must say, I think where Canada, Alex, we talked about this so many times, where Canada really leads in the area of trauma and PTSD is that we have a small, close-knit community. We know each other, we like each other. And I think that's where Canada's leadership comes in so many parts of this, this desire to understand has come through those close relationships.
Well, and I guess I'd say that researchers like you bring me hope because you're so committed to finding answers to address the issues that real people are facing across the board, as you say, Margaret. Even people like funeral directors, who would have imagined that they might have become involved. What I'd like to do now is transition. There's an opportunity for people to ask questions, use the Q&A box at the bottom of the screen, and we'll get through as many of these as we can to make this efficient. Our HRI's communications coordinator, Becky Rothwell, will handle this part. Becky?
Thanks, Roy. We're getting actually, quite a few questions coming in. I don't know that we're actually going to get to all of them this evening. But I might suggest that if there are questions that we don't get to and you want to connect with us directly, please do so. You can visit hriresearch.com and get connected via email or social, just because some of these questions are really intriguing, and it might be nice to close the loop on them. So I'll start with a few. The first one here: if people in general are in potentially traumatizing situations, is there anything they can do to avoid being seriously traumatized?
I'll start with that, Alex.
Sure. Sorry, did you say you're going to take it, or do you want me to take it?
Do you want to start?
Sure, I'll start. So how can people I guess, reduce the risk of ending up with a more serious kind of trauma problem or trauma disorder? It's a great question. Again, the research, the worldwide research, what we know in terms of risks for developing PTSD following a traumatic event, there are a number of risk factors. But again, so for example, having had an emotional or mental health condition in the past can be a risk factor. certainly a history of childhood abuse or problems can be a risk factor. Um, so there's a number of things that we know that from your own history can, when you're traumatized, increase risk. But it's the issue actually that is shown to be the most reducing of the risk or preventative of the risk of developing PTSD is to have social support. So one of the biggest risk factors, to say that the other way, is to have lack of social support at the time of and after the traumatic event. So again, it's one of the reasons why Margaret and I think we talk so much about building in that support with other people, because we know that it's one of the most protective factors that we have. Do you want to add something to that, Margaret?
Yeah, I think that's a wonderful answer. And, just thinking about again, what has helped you in the past, right? And I think sometimes we've given up some of those things during the pandemic because we had to. And, I hear over and over again from healthcare workers, so interestingly, exercise is one very big thing. And that's, of course, not going to be a cure all. But I think, going back to some of those things in the past that really helped you, I think that's a really important step right now for people as much as they can to be able to do those things because we've been so restricted for so long. And even when we can't be together physically, keeping up that connection. Um,
Thanks so much. I have another question. Actually, several people have asked this question or similar. How do people know if they need professional treatment for trauma? What advice would you give to people seeking help? How do they find their way?
Why don't you start with that one, Margaret?
Okay. So, I think there's a number of different, and we all have a different threshold for how much we can tolerate, right? So, the traditional definition would be that if you find that it's interfering with your work or home or social functioning, many people say that's the point where you reach out for help. But I think we have to take an individualized approach to that and think about what our threshold is. How much can we tolerate, and when do we think it's time to reach out for that professional help? There are a number of resources, and I want to acknowledge writ large that we don't have enough resources in place for mental health, and I think we often hear that from patients, and we want to really acknowledge that here that we don't. But there are resources available for healthcare workers here in Ontario, across Canada. There's the Wellness Together portal where people can seek support. I think the first thing though often is going to your GP, talking to your GP, seeing if he or she can provide a referral in the community. I think that's very important. It's not an easy path, and we're not going to pretend that it is, but I think sometimes the persistence as well in seeking those supports is also important. What would you say, Alex?
Yeah, let me just add something to that in terms of all of us to be thinking a bit more, I guess, in the wider social aspect, or you know maybe the socio-political aspect, is to think about issues like provision of healthcare and provision especially of mental health care, because it is really true that we have a wonderful, wonderful public healthcare system in Canada. But one of the things that COVID has done, of course, is it really exposed the cracks in that system. And I think we have a real opportunity now, rather than with the end of COVID, maybe just kind of going back and still kind of just trundling along with the way we have been, to say, okay, how do we want to improve this? Because you know what? This is, and again, it goes back to that thing about how do we want to take care of each other in our times of need. So I really would implore the audience to, for each one of us to think about what's the opportunity here for me, for us, to try and do something to improve that system that Margaret says is, certainly it's true. It has gaps and holes, and we there are things we can do to make that better.
Yeah, I agree, Alex, because I think when we say, call your GP and go here and go there, we also need to really acknowledge how difficult it could be to find that help. And I just want to acknowledge that for people in the audience because I know We hear that over and over and over again. Um,
Margaret, is it worth talking about wellness together as another way for people? You've mentioned it briefly, but I think that's a wayfinding opportunity as well.
Yeah, certainly. And this is really falls under the federal framework for how we've responded to the pandemic. And so the Public Health Agency of Canada stood up the Wellness Together portal, where Homewood Health is indeed the main service provider for that. And it provides resources for Canadians all across the country free of charge. You can have access to a counselor, there's access to resources that you can do online. And again, it's that reaching out for the support that's available. It's so important.
Mhm.
So I've had friends do online approaches during the pandemic, and it's not ideal at all. But even if it just does a little bit, I think while you're waiting for something else, I really encourage people to look for those resources.
Yeah. And you know what? I think sometimes it is ideal. Like I think sometimes for people that that resource that's right there and can be just what the person needs to kind
Absolutely.
of just help get them started. So one of the interesting things too about Wellness Together Canada is that it's built on what's called a stepped care model where
Yes. Yeah.
basically it says, you know what, not everybody needs to be in a hospital when they have a problem. Not everybody needs to see a psychologist or a psychiatrist. Sometimes people need something um, important, but that can be delivered much quicker and that will still be helpful to them. And then, you know what? The system should be built for people to be able to step up to the level of care. And then when they're feeling better, to step down again and have different levels. So, for example, yes, first of all, there's a wonderful a crisis service offered through Homewood Health on Wellness Together. But there are other services. There's a real time chat function where people go in and they write stuff, and it's kind of like peer support forums there, but it's a well regulated and sort of moderated um, entity where people can feel safe. And in fact, they sometimes, people will go on and say, again, if there's 3 or 4 nurses, they kind of identify themselves as nurses and they can form their own sort of private chat group. And
Wonderful.
yeah, and again, it's simple.
That's wonderful.
Yeah, it's simple and it's very, very available. And I think often it's very helpful for people.
I think that's and yeah, it's so funny too when we think about healthcare workers and public safety personnel, the ability to be online is so good around shift work, right? Because
Mm,
that is an incredibly significant barrier, which we often
mm,
don't talk about, right? And we've moved treatments that we've developed here at Homewood, research institute that we've been working on, we've moved them online, and we've had really good feedback. Interestingly, I mean, for some people, there's always going to be the preference for in person, but for some people, that has actually
mm,
been a benefit, right? Like you can be leaving the fire hall and
mm,
you want to call on your phone. You could
mm.
be going home from the hospital, at midnight and accessing something. And I think that availability of mental health supports that aren't 9 to 5 is also really important, but particularly for this community.
I
Communities.
agree.
Yeah, yeah.
Margaret and Alex, I'm getting a few questions that are in a similar vein, and maybe the Wellness Together portal is a good option, a good starting place. But for people who are either, the first question is about long-term effects of COVID-19 stress on caregivers, and then in a similar vein, other folks who are in support roles or who may be a home healthcare provider but may not qualify as a healthcare worker. Would there be different recommendations or resources that you'd suggest?
Yeah, that's a very big question. I mean, oftentimes, one thing I will say is that oftentimes people aren't necessarily aware of their EFAP benefits. So, one thing to really explore as much as possible is to work with your employer to see what is available to you through your employment family assistance plan. We have often found that people don't necessarily know, and that's not for everybody. Obviously, many people do not have access to that. But is one starting place. Again, the online resources is something talking to your GP, but also recognizing part of the moral injury of this pandemic is that there's been an inequity for healthcare workers. And certainly when we think about the pandemic pay in Ontario that was available to some healthcare workers, but not to others, that was incredibly difficult within hospitals, for example, where a person would be working alongside someone and providing similar care, but one healthcare worker was receiving that pandemic supplement and one wasn't. And so I think when we think about healthcare workers, it's so important for us to think about the broad spectrum. And healthcare workers aren't just those with license designations. They include people who are in facilities, people who are providing environmental services, people who are providing food. Everyone is working together as a healthcare worker right now, and it takes the whole of the healthcare organization to provide the care, particularly right now.
Mhm.
I really acknowledge that.
Yeah. And then I think we need to think about even within healthcare, those groups that are more disadvantaged or more marginalized, like uh, care workers
Yeah,
in long-term care homes, or sometimes who are also going into people's houses to provide care, but they don't they're first of all they're paid much less money, and they don't have those same kind of benefits and protections that others do.
yeah,
And I think they've really been disadvantaged disproportionately during COVID.
I agree, Alex. And I think as you said, like as we come, at some point to the end of this, we don't want to go back to where we were. We want to think about what's the brighter promise of a brighter world. And where can we address some of these inequities and where can we recognize everyone for their contributions? Because we certainly learned throughout this that we need to hold on to one another.
Yes, I agree.
We have just a couple minutes left for the Q&A, so I think we have time for one more. Um, and one that I'm getting a few similar questions to this. What would be some appropriate policy responses given this work and your findings and what's happening in the world today?
May I start with one comment, Alex? Is that all right?
Sorry.
May I start with a comment? Is that
Oh,
okay?
of course, yes, of course. You can
Thank
start.
you. Okay, so this is one thing that I really am passionate about. So in Canada, many workers across the provinces have something called presumptive legislation, and that is extended primarily to first responders and nurses in some provinces. And what that means is that when you submit a workplace disability or workplace injury claim, if you belong to these professions, it's presumed that your PTSD is related to a workplace injury. Healthcare workers, with the exception of some nurses, do not have that presumptive legislation. And so when we look at what's happened over the course of the past 19 months, I think it's pretty clear that healthcare workers are also suffering from trauma. Some will develop PTSD. And there is this very artificial boundary between the inside of the hospital door and the outside. And I think we need to take that boundary away and think that we're all in this together, that healthcare workers really should be extended that same presumptive benefit. I really do believe that. I feel very strongly about that, to allow them to receive the care that they need. And also as a way of us saying thank you back to them for everything that they've done, everything they've sacrificed over the course of this pandemic.
Um, if we have another minute, let me just add something to that, because in fact, that idea of presumption was part of the basis of the PTSD Act that was passed in Canada in 2019. And that act, I think we're the first country, we're certainly the first country I know of who's actually passed an act to recognize post-traumatic stress disorder as something that can be caused by your occupation or your situation. And so it was very much focused on public safety personnel, but a number of other groups came forward at the time that the act was being debated, and nurses in particular at that time. And so this was pre-COVID, and they said, nurses should be recognized within this. So I think it's another thing that hopefully over the next few years there will be more action in that area. And certainly when we were writing the federal framework on PTSD, we in fact expanded our definition to include these other groups. So it wasn't focused, it was important for sure to be acknowledging first responders, but we wanted to include these other groups of people that we knew were also suffering because of workplace mental health injuries.
Yeah, also, I want to thank you. And if I could just acknowledge a very special group who we've been working with quite a bit is respiratory therapists. And respiratory therapists are often the ones who are involved in the ventilation. They're often the ones holding the intubation,
Intubating, yeah.
intubating, and often left holding the hand of the individual when they lose their life. And those individuals they think of themselves as the first responders of the hospital. And I think very rightfully, they're called all across the hospital in very difficult situations. And we've been surveying them across the country and hearing their stories. I just want to say we stand in salute to them this evening and all the work.
Thank you for those. Thank you so much for those comments. As we wrap up, it sounds like a lot of this distills down to, at an individual level, be kind to yourself, support each other. If you're an organizational leader, have people's backs, convey to them that you understand what it is they're going through and you're walking with them, even if you don't have all the answers. And both of you are showing that your commitment by moving in this policy direction, really trying to ensure that what people need is available to them through appropriate legislation. As we close, there are a lot of thanks to make tonight. The first thanks I want to extend actually is to frontline workers, healthcare workers, first responders, public safety personnel, and all the other people, whether they're working in grocery stores or funeral homes, who have really extended themselves on behalf of all of us through this pandemic. We're very grateful, and we want to do our level best through our research to find solutions that actually ensure that you have the resilience you need to move through this effectively. Margaret and Alex, I want to thank you so much. You're obviously very busy people with research, policy, and many leadership roles that you have. Thank you for your dedication. And it's not, you too are on the front lines in many ways. You're absorbing a lot, and thank you for that. I want to thank the audience who took time to join us tonight. I want to let you know that you'll get an opportunity to do a brief survey in a follow-up email. I hope you'll take advantage of that. We want these talks to be the best they can be. And the way we get there is to have your feedback so that we can use that to shape the future. If you go to the HRI website, you can learn more about us, and you can subscribe to our newsletter, for example, if you're interested in staying abreast of what we're doing. And you can also go there to find the link to the YouTube channel or the YouTube recording of this session if you want to share it. I want to thank the HRI staff. A lot of work goes on behind the scenes. I won't single people out, but this team has done a great deal of work. I particularly want to thank our sponsors again, CIBC, KPMG, and Fusion Homes, for their public spiritedness in supporting HRI to enable us to bring a series like this to the public. I want to let you know that the next HRI talk is on November 3rd. It will focus on the measurement of treatment outcomes after people finish treatment in mental health and addiction services so that we can better understand the recovery process and so that we can learn how to improve programs. So I hope that you'll set aside that date. And there'll be two other topics in the future before the end of March. One will focus on addiction and one will focus on the microbiome in mental health. Again, I want to thank everybody who's participated. We really appreciate everything you've contributed. Thank you and good night.